about something which is in sync with this year's World Health Day theme of depression. Let's talk. We'll talk about childhood depression, which almost seems like an antithesis because for many of us, childhood means a period of unbridled joy. So, what does the prevalence statistics say? How common is this problem? 1 in every 33 children and 1 in 8 adolescents are depressed. According to the British Psychological Society data, suicide is the sixth leading cause of death for children between 5 to 14 years old. So why this disparity? Why less prescriptions of childhood depression when the data suggests otherwise? And what is seen is that even in Western cohorts, about 75% of children and adolescents with very clear signs of mood disorder remain undetected. The fact that only about 1/3 of parents would like to talk about psychosocial concerns in their children leads to a lot of unmet needs for these children. So what are the risk factors for childhood depression? And it's an amalgamation of stress with vulnerability factors. So negative life events, many times unavoidable, along with vulnerability factors such as exposure to war trauma or calamities, socioeconomic deprivation, orphanhood, comorbid psychiatric disorders, and poor child and parent relationship leads to depression, according to the diathesis stress theory. Now, we said childhood depression is not a common prescription, but chronic medical conditions are. And what is seen, this is just an example, that in many studies, there is significant association of early onset depressive symptoms and functional impairment with chronic medical conditions in children. Now, this is the whole umbrella of depressive disorders according to DSM-5. What I want to highlight is that other than major depressive disorders, disorders associated with another medical conditions, substance abuse are important aspects to the depression in children. Now, if you look at depression, it's basically a spectrum which goes from bereavement to sadness to adjustment disorder to dysthymia and finally major depressive disorder. A word on dysthymia, well, it is very similar to major depression, only the symptoms are milder, but it tends to be more chronic and thereby disabling for the child. Now, what are the clinical presentations? And it varies according to the developmental age. So preschoolers with their inability to express sadness will present as failure to thrive child without an organic basis, speech and motor delays, decrease in interactiveness, withdrawal, poor attachment. All those would be pointers towards depression. School children tend to internalize all the conflicts and anxiety in their environments and manifest it as excessive anxiety in forms of school phobia, separation anxiety, somatic complaints of recurrent headaches and pain abdomen, and these are very common causes of OPD visit. School failure many times is the first sign of depression in a child. Loss of previously learned skill and temper tantrums are also presentation for school-going children of depression. Now, adolescents tend to present as adults and their presentations are mostly in form of behavioral problems, substance abuse, delinquencies, and conduct disorders. Sleep and appetite disturbances are also a manifestation of depression, but the red flag sign remains suicidal ideations and self-injurious behavior. So adolescents with symptoms of depression should be screened for suicidal ideations very carefully. Now, it's said that misery loves company. So about 70% of depressed children also have another comorbid psychiatric disorders. These comorbidities are mostly in form of anxiety disorders, attention deficit hyperactivity disorders, and oppositional defiant disorders. In adolescents, substance abuse disorder is a very common comorbidity with depression. Now, let's look at the DSM-5 criteria for diagnosis of depression. And what is important is to note that of these 9 symptoms, 5 should be present for at least 2 weeks and the same 2-week period. One of those symptoms has to be either irritable mood or anhedonia, and then another 4 in form of indecision, decreased concentration, sleep problems, change of appetite, excessive fatigue, feeling of worthlessness, suicidal ideation, and psychomotor agitation. So one of the first two and another 4 should be present for 2-week period to be classified as depression. Now DSM-5 also categorizes the severity of depression based on number of symptoms, their severity, and the kind of functional impairment that they bring. So mild depression would be something which would just qualify as depression with only 5 of those 9 symptoms. The severity is distressing but still manageable, and the functional impairment that they bring is only minor. On the other end of the spectrum, severe depression is something which will take most of those 9 symptoms, will be very distressing and unmanageable, and there would be a marked interference in social and occupational functioning. Moderate disorder is something which doesn't fit in either of these categories and is an in-between thing. Now let's start with assessment of childhood depression. And what is important is to note that there are many medical conditions which may mimic depression, hypothyroidism and anemia being good prototypes. So detailed medical evaluation is warranted in all children. Patients with depression risk factors should be identified and systematically monitored. It includes interviews with the patients and families, and we should make a very careful assessment of the functional impairment that these symptoms are bringing about. For diagnosis, DSM-5 criteria that we mentioned is a valid and reliable tool. However, especially in preschoolers, screening tools such as pediatric symptom checklists are a good option to screen for it. Answers of never, sometimes and often, you give scores of 0, 1 or 2. And if the cumulative score is more than 24 for preschoolers, more than 28 for children between 6 to 16 years of age group, and more than 30 for an adolescent, they would qualify as childhood depression and would warrant detailed assessment. Now coming on to the management, and it has basically 2 wings of psychotherapy and pharmacotherapy. Psychotherapy is considered the initial therapy for children and adolescents with mild to moderate depression, and it goes along with pharmacotherapy in cases of severe depression. Now there are various modules to these psychotherapies, starting with self-modeling and relaxation, social skill training for mild depression, and it intensifies in form of cognitive behavioral therapy, parental sessions, interpersonal therapy for children with severe depression. The details of these sessions of psychotherapy are beyond this module. Now, pharmacotherapy, and you can see it in form of 2 wings of SSRIs and tricyclic antidepressants. What is seen is that fluoxetine is the best among antidepressants. Other antidepressants, as far as this Lancet paper is considered, are not suitable for routine treatments. Fluoxetine can be considered in children with moderate to severe depression, especially if they are adolescent. If there is no access to psychotherapy, something which is very valid in low income or middle income countries, and those who do not respond to psychotherapy. Tricyclic antidepressants may benefit children with mild to moderate depression if there is an associated ADHD or enuresis. But what is very important and an FDA black box warning is that there is a small but statistically significant increase in suicidal ideation after starting of pharmacotherapy. So these children who have been started on any antidepressant should be screened for suicidal thoughts. Now, a multidisciplinary management is must in all these children. Child psychiatrists, psychologists, counselors, social workers working closely with a pediatrician is essential for their appropriate management. Absolute indications would be severe depression, a very young child, those who are refractory to the first line therapy, be it psychotherapy or medical therapy, and if there are significant comorbidities, multidisciplinary management is the way to go. Now, course of childhood depression, and about 10% of children would recover spontaneously within 3 months. However, 30% of cases recur after within a period of 5 years, and many of these children would take these episodes into their adult life. So a long-term follow-up is warranted. The most serious complication remains suicide, and there is a 3% risk over next 10 years. Now, sort of summarizing, and this is the stepped care model proposed by the British Psychological Society, where we need to detect depression on basis of risk profiling, recognize it using the questionnaires, and then based on the severity of depression, you can start with non-directive supportive therapy or watchful waiting to a combination of pharmacotherapy along with psychotherapy. The management algorithm from American Academy of Family Physicians, and it's basically same. What I want to highlight is that if after 6 to 8 weeks you find improvement, let's say on pharmacotherapy, the medication should continue for 1 year. Starting the pharmacotherapy is important, and maintaining it is also important, because if you stop it prematurely, there are chances of a recurrence. Long-term follow-up is a must, so the minimal follow-up should be of at least 24 months. The final word, and this year's World Health topic was depression, let's talk, and it's valid for childhood depression as well. But for pediatricians, childhood depression also means the need to identify, screen, treat, and prevent, because it's much easier to build a child than to prepare an adult. Thank you.